Hi, my name is Stormy Copeland, and my presentation for pathology is on appendicitis. First, I just want to go over the normal anatomy of the appendix. It's a long tubular structure extending from the cecum. It's the remnant of what was originally the apex of the cecum. It's located on the abdominal wall under the McBurney's point. Now, this point is if you draw a line from your right anterior superior iliac spine to your umbilicus. About midway is where your appendix sits. It has a variable line in the body. It can be branching off in several different directions. It varies anywhere from 1 to 9 inches in length. However, it usually averages around 3 inches. The maximum diameter can be up to 6 millimeters. The artery that supplies the blood to the appendix is the appendicular artery. It is a branch off of the ileocholic artery, though. As of right now, and pretty much just throughout all the research that I did, there is no known physiologic significance of the appendix. It's more or less just an appendage off of the cecum. Now, appendicitis is basically just an inflammation of the appendix. Just breaking down the word, appendi, and then citis would be inflammation. It's the most common surgical emergency in childhood. It can occur at any age, but it's most common in younger ages. For women, typically if you're between 20 and 40 years old and you have appendicitis, you're going to be misdiagnosed for reasons such as, ovarian cyst rupturing or anything related to like pelvic areas. They're normally going to think that that's what it is first before diagnosing you with appendicitis. If appendicitis goes on for too long untreated, it can perforate, which basically means it'll leak out, the contents within it will leak out into the area around the appendix. It happens more rapidly in younger children, sometimes within 6 to 12 hours of onset of symptoms. Just for perspective, the rate of perforation in a preschool child can be seen as high as 70% compared to the overall 30% for pediatric patients and a 21 to 22% for adults. So, let's see. It usually will show signs of diarrhea and fever. Your patient might even be vomiting or feeling like they're going to vomit. They'll have a rebounding pain, which means you can press on their right lower quadrant and it'll ease the pain when you have pressure applied, and then when you release, the pain will return. And of course, that's going to be over that McBurney's point. You'll also have leukocytosis in labs, so check for white blood cell count. If it's elevated, that's usually signs of infection. Of course, it's caused when that lumen of the appendix becomes obstructed or inflamed, and causes for this can be a wide variety of fecal matter, foreign bodies, carcinoma of the cecum, simple stenosis, and inflammation. If it kinks to one side or the other, it could possibly cause it to be inflamed, and then lymphatic hypertrophy is also another reason. So I'm going to show you a normal appendix. Normally, you would not see this. It is that structure running right across where the arrow is pointing. Normally, you would not see these just because, unless you have a very thin patient, they're normally going to be obscured by bowel or just like the body habitus is just not going to let you see it. If it's normal, you can sometimes see it in younger patients very well, or, like I said, thin patients, if you kind of gradually compress it. It is compressible, and in children, you'll see a hypoechoic band that won't fold, and that kind of makes it distinguishable from bowel and the appendix. However, that band does disappear as you get older, so it'll be harder to differentiate later on. Now, for appendicitis, the ultrasound findings, there's going to be a very thickened muscular wall, and then in transverse, it'll have a target-shaped appearance like this. It'll look very target-shaped, and you will measure it from the outside of the muscles just to determine how thickened the muscle is in general. Also, you'll have that increased appendicular diameter of greater than 6 millimeters. Remember, anything less than 6 millimeters or up to 6 millimeters is considered normal. However, if it gets above that, that is a good sign of appendicitis. It also lacks peristalsis. If you see it and you aren't quite sure if it's a bowel, press on it a few times, make sure that there's no movement. If it becomes non-compressible, that is usually another sign of appendicitis. If you put color Doppler on it, there will be an increased blood flow to it. And you might even see these little calcified stones in the appendix called appendicolus. I have a picture of one of those. This whole area right through here is the appendix. As you can see, compared to the other image, it's extremely enlarged. And then this hyperechoic echogenic place right here is the calcified stone in the appendix. Okay. Also, with appendicitis, to diagnose it, you have to be able to show the thickened wall on ultrasound. The target-shaped appearance is also used to diagnose it, and the lack of compression. Also, they'll look at lab work and, the symptoms that the patient presents with. Another modality, so to speak, is using contrast for either CTs or MRIs, or even X-rays can be used to diagnose appendicitis. Treatment-wise, most of the time, by the time it is caught, it's an emergent surgery type thing. You're going to be rushed straight into the ER and they're going to remove it. However, if it's more of an incidental finding, like you're scanning through and you see it and it kind of looks a little enlarged, but not to the point where the patient's actually showing symptoms yet, they might prescribe antibiotics and then do a follow-up later on. Some differential considerations, if you do see what looks to be like appendicitis, would be acute gastroenteritis, which is that inflammation of the small bowel. You can also have mesenteric lymphodemus in children, ruptured ectopic pregnancy. Because it's so close to the pelvic region, it is sometimes can look or mimic an ectopic pregnancy, or it could even be an ectopic pregnancy. Mittelschmerz, inflammation of the mucous-diverticulum, regional enteritis, which is that Crohn's disease, and even right ovarian torsion can mimic or even be mistaken for appendicitis. Here's some more images. This is appendicitis that has perforated or slightly ruptured. This area down here is the appendix. And all this up here is a abscess of pus that has come out of the appendix. And normally, obviously if you see that kind of stuff on ultrasound, they're going to take them to surgery and remove all of that. And this is the same thing. You'll have the appendix, and you can obviously tell where it has ruptured out. And same thing over here. This is the long axis, and it is ruptured out right through here. Okay, and that's all for that. My works cited or sources was an article on appendicitis in children, the Hagen insert book, and radiopedia.org.